We were talking about hyperkalemia. We're picking up where we left off. Navigation issue. So, here we go. We had covered the hyperkalemia, excuse me. So now we're going to move towards hyperkalemia due to transcellular shift. Okay. And as I mentioned, we'll go back and forth between this algorithm and the texts. So let's start in the text though. Okay. So transcellular shift can obviously cause hyperkalemia because intracellular space is where 98% of total body K resides. And if you have a problem with intracellular compartmentalization of K, it can cause hyperkalemia. You'll recall a correction I had from last week's Escuelita that rather than intracellular K concentration being as low as 100, it really is in the variable literature 130 to as much as 160. So please incorporate that correction. But still, it's quite high in comparison to ECFK. Okay, and so grounded in that starting point, let's go ahead and cover some of these topics. Where's my delete? Well, okay, so mannitol infusion, if it's a hypertonic mannitol infusion, can cause a solvent drag of sorts where water from the intracellular space is moving solute from the intracellular compartment into the ECF. Again, anything that causes increase in ECF tonicity, including hypertonic mannitol, could potentially do that, okay? Now, hyperglycemia is certainly the more common cause of this enhanced transcellular shift of ICFK to the ECF. Looks like my whiteboard is still trying to come online. Succinylcholine is another one that is the result of depolarizing paralytics. Here we go. Looks like we can work now. There we go. All right. So again, we have high intracellular K concentrations somewhere between 130 to 150. And again, the movement of solvent driven by increased tonicity, such as hyperglycemia, would have this high intracellular K content translocate into the ECF, okay? Now, succinylcholine is, as you know, a depolarizing paralytic. And you recall, I hope, the action potential, right, which we discussed in a prior conversation. Let's go over the relevant point. Remember, your resting membrane potential is negative. The action potential requires this less negative or this upstroke in the resting membrane potential. As sodium moves into the cells, what repolarizes the cell is the egress of K from the ICF to the ECF, right? So if I'm using a depolarizing paralytic, then this rush of, or this repolarization step can cause transient hyperkalemia. Now, there are clinical scenarios in which this is more likely to occur. Those are listed here. Essentially, what they have in common is a disuse state. What happens is that as there is a low frequency of stimulation of muscle contraction, then there is an increase in some of these acetylcholine receptors that are part of the signal transduction of a neuron telling a muscle to contract. With that increase in acetylcholine receptors, when you ultimately do send a contraction signal to that muscle, it has an exuberant response. Okay, and so there is aggressive depolarization, let's say, of that muscle cell and the population of muscle cells that resides in the tissue, and that repolarization step in which potassium is leaving the cell results in a transient increase in ECFK. Okay, hopefully that makes sense. Again, it's really people who are essentially bedbound or some of these other clinical states that have a higher risk of this phenomenon occurring. Okay. Let's move on to digoxin as a cause. That is another example of transcellular shift as a main cause of extracellular K excess. Remember, this is not a total body K excess. This is simply K is in the wrong place, right? Instead of being predominantly in the ICF, there's a disproportionate increase. There's a relatively significant increase in ECFK content, which is manifest as hyperkalemia. Digoxin, as you recall, works by inhibiting sodium potassium ATPase activity. Okay, that's one of the reasons that digoxins, or one of the mechanisms of digoxin's effect. Okay, and of course, you recall that one of the ways, I'll use a different color, one of the ways in which you create this very high K content on the inside of cells and a relatively high content of sodium outside the cells is this through the effect of this sodium potassium ATPase, right? So it stands to reason, if I reduce the activity of this transporter, then the compartmentalization of K in the cell is inhibited and the ECFK concentration can therefore rise, okay? So again, dig toxicity is a known cause of transcellular K excess or inhibition of transcellular transport of K, resulting in an ECFK concentration that is quite high. Okay. Now there's the other effect of digoxin in increasing contractility, which is separate from this, which involves an increase in intracellular calcium concentration. Remember, calcium is your signal for muscular contraction. Calcium leaves the sarcoplasmic reticulum in order to enhance muscular contraction. So that's the way that digoxin manifests an improvement in contractility, but the K phenomenon revolves around its effects on sodium potassium ATPase. Everybody good with that? All right, let's move on then to the beta blocker. Beta blockers are a cause of transcellular K transport inhibition. And there's two mechanisms, one that surely you know, the other that might require a little bit of explanation, right? The one that you know, because you leverage it even when you were a resident, is if I give you a beta-2 agonist, such as albuterol, that helps me manage hyperkalemia, right? So what's happening is that the administration of a beta-2 agonist stimulates the activity of sodium potassium ATPase and helps then transport more K into the cell, right? You leverage that therapeutically through the use of beta-2 agonists, such as albuterol, right? Now, so it stands to reason, if you use a non-selective beta blocker, right? A beta blocker that blocks not just beta-1, but beta-2 as well, you would inhibit the intracellular compartmentalization of K. So that's a manifestation that can sometimes be, or that is a physiology that can sometimes be manifest in the clinical realm. However, I would never attribute that as a sole explanation for hyperkalemia. You typically need other factors at play in order to manifest clinical hyperkalemia from the use of non-selective beta blockade. whether that be CKD or a little bit of hyperglycemia. Those would be part of a sum total explanation of hyperkalemia. Okay, so the other way that beta blockers, even even selective beta blockers can contribute to hyperkalemia is through the inhibition of renin release. Okay, so renin release is regulated, we've already learned, by afferent arteriolar stretch, right? We have our glomerulus, we have our afferent arteriole, we have the granular cells in the vascular wall of the afferent arteriole. One reason that renin is released is when there is reduced stretch of this afferent arteriole by decreases in effective circulating volume, right? Another way that renin release is regulated is through beta receptors, in this case, beta 1 receptors. Okay, so beta 1 stimulation stimulates renin release. This might map back also, I'll have you think on your own about how beta antagonists can affect renin and aldo ratios, right? You'll think about that on your own. We talked about that recently in Dr. Price's lecture on secondary hypertension. But again, if I use even a selective beta blocker, theoretically, I can cause a hyporeninemic hypoaldosteronism. Okay, and so impair, this is not transcellular shift in this case, that would be impairing renal K wasting, right? If I cause hyporeninemic hypoaldosteronism, we'll talk about that some more, okay? But that elucidates how even selective beta blockers, not through effects on transcellular shift per se, but an effect on aldosterone secretion, which we're going to talk about here shortly, can also contribute to hyperkalemia, reduced aldosterone. Now, let's talk about metabolic acidosis. Metabolic acidosis can cause hyperkalemia. Our cartoon version of this, I think I need to get a fresh scratched paper here. Our cartoon version of this is that when proton concentrations in the ECF rise, then I have an increase in intracellular proton concentrations as well. Protons being a cation force the transcellular shift of a balancing cation into the ECF, right? That's the cartoon version of how acidosis can contribute to transcellular shift, hyperkalemia, right? The reality is that there is not this sort of transporter mediated transcellular shift of protons and potassium. There's a middleman. There's basically a transporter that is a sodium proton transporter. You may recall that you have sodium proton transporters, antiporters in the proximal tubule. That's how you reclaim bicarbonate. You have sodium proton transporters in other cells as well. This is another classic example of repurposing of genes and transporters that is done throughout the body. So you have sodium proton transporters. When there is this intracellular acidosis that occurs, sodium is leaving the cells, right? If sodium is leaving the cells, then I have less favorable intracellular compartmentalization of potassium by sodium potassium ATPase. Okay, does that make sense? So it's an indirect effect of acidosis, really essentially decreasing sodium potassium ATPase activity. Okay, all right, but the net effect is the same. Now we state that this is mostly it's most likely to occur with organic acidosis. Okay, this does occur to some extent. I need a fresh paper again. This does occur to some extent with any acidosis, but it is most manifest through mineral acidosis. Why is that? Is that because when you have an organic acidosis, such as lactate, okay, plus the proton, you have these transporters that not only transport protons in the cells, but simultaneously transport that conjugate base through an organic anion transporter. And so that net that net effect on transcellular charge, okay, is not necessarily then pushing this potassium out of cells, right? If I carry a negatively charged conjugate base with that proton, the influence on potassium pushing it outside of the cell will be diminished. Okay, everybody get that? So that being said, even with severe degrees of organic acidosis, there is some of this transcellular shift that's happening. And it's relevant to your clinical practice. What I would tell fellows, if they're doing an emergency dialysis in a patient who has a K of 6, right? But their bicarb is also 6. Let's use similar numbers, right? Severe single-digit acidosis. I would not tell the fellow to use a 2K dialysate. I would say run this patient on 4K dialysate, because when you correct this severe in acidosis, you will get a lot of transcellular shift of K, in this case, into the cells. The opposite of an acidosis is you're correcting an acidosis. So K is going to go into the cells. If you dialyze against a 2K dialysate, you're going to get hypokalemic afterwards, okay? All right, so I think I fleshed out the effect of acidosis. I've made statements in the text about the individual effects of organic metabolic acidosis versus mineral acidosis. Let's then move on to a unique form of transcellular shift, and that's hyperkalemic periodic paralysis. We talked about, again, the clinical relevance of hyperkalemia, and said that the clinical effect of hyperkalemia is most prominent when you have an increase in K content in the ECF with a decrease in K content in the ICF. That is the worst case scenario that maladapt, or that causes a electrical instability across the cell membrane, okay? On the other hand, in most cases of hyperkalemia, chronic hyperkalemia, I have an increase in ECFK plus an increase in ICFK, like a CKD patient with hyperkalemia. This minimizes the influence on the resting membrane potential of the cell, and therefore minimizes the physiologic effect. Hyperkalemic periodic paralysis is the worst case scenario, okay? It is a scenario in which there is transcellular shift of K from the ICF to the ECF, and these patients, even though their hyperkalemia may be a modest 6, are profoundly symptomatic, right? They are literally paralyzed. They fall when trying to get out of bed, for instance. Okay, so the physiology of this syndrome is interesting. It, generally speaking, is not a problem with a potassium channel. The hyperkalemic and hypokalemic periodic paralyses are really disorders of sodium and calcium channel biology, okay? So here is the causal mutation. It's a sodium channel that modulates skeletal muscle depolarization, and ultimately results in a transcellular shift of K from the ICF to the ECF, okay? So the interesting precipitating effects or precipitating factors for hyperkalemic periodic paralysis is an increase in potassium intake, rest after heavy exercise, are classic examples of precipitating factors for hyperkalemic periodic paralysis. We'll see in hypokalemic periodic paralysis other examples. Exercise is another precipitant of hypokalemic periodic paralysis. The other is spikes in insulin. Okay, so we'll compare and contrast the two once we get to hypokalemic periodic paralysis, both in terms of the causal factors. We'll drill down a little bit more to the physiology, but here I'll just start with the overview. Okay. Now, these patients will have hyperkalemia during the attack, and in between attacks, they'll have normal kalemia. You, however, can elicit certain characteristic signals on electromyogram to make the diagnosis. This will typically be done not by nephrology, of course, but rather through a referral to a neuromuscular specialist. But now we're more and more using genetic testing for making a number of renal diagnoses. Now that you have renocyte testing, you'll capture these in renocyte testing as well. So we're relying more and more on genetic testing as opposed to some of these functional assays for hyperkalemic and hypokalemic periodic paralysis. But there is still the possibility of referral to neuromuscular. Exercise is another scenario in which you can get transient hyperkalemia. The most classic example of this will be in the patient who has tonic-clonic seizures, so intense muscular contraction that is happening rather suddenly. Remember, it makes sense why that will be the case, because relaxation or repolarization, I guess is the more accurate statement, requires K moving out of the cells. And so if you have, severe contraction of muscles throughout the body, and then those muscles are repolarizing, you can catch them in that phase of transient hyperkalemia during repolarization of that excitatory tissue. Okay, so again, post seizure is a classic example in which muscular contraction can cause hyperkalemia. Sometimes these patients also have severe lactic acidosis with single-digit bicarbs. That can be another factor at play causing transcellular K shift into the ECF.
How long does the hyperkalemia last?
Typically, less than an hour, I would say. Okay, these are things that you should not sort of rely upon if you have hyperkalemia beyond that hour. All right, so let's move on to talk about total body K excess. So transcellular shift is not a situation in which there's total body K excess. Again, we've highlighted in this algorithm some of the examples: hypertonicity, digoxin, non-selective beta blockers. We've highlighted several of these. One that we didn't talk about specifically is when you have death of tissue or injury of tissue, such as with severe rhabdomyolysis or tumor lysis syndrome. That would be another example in which transcellular hyperkalemia or transcellular shift can cause hyperkalemia. Okay, now we're going into situations in which you have total body K excess. And the main questions you're asking now is the kidney responsible, or is the kidney, trying but failing to maintain normal K homeostasis? So one of those primary ways that you make that you meet that first, or you parse that fork in the road, is by looking at urinary K excretion rates, right? If the kidney is trying to respond appropriately to hyperkalemia, you should see that K excretion is vigorous. Okay, let's give you a sense of what are normal K intakes, and then that can give you some context as you're interpreting these values. Normal K intake is somewhere around 1 millimole per kilogram per day. So if you're in homeostasis, you're somewhere around that. The healthier the diet, more fruits and vegetables, the more K you have in your diet, the more fast food and such, less K, you're going to have more sodium in your diet, less K in your diet. So again, that varies according to the health habits of the individual, but some ballpark is 1 millimole per kilogram per day. That being said, if I put you on a progressively high K diet, even as much as 400 millimoles per day, akin to what our ancient ancestors were eating, the bone marrow that they're sucking out of the bone and all those fruits and vegetables, the berries and such that they're finding in the environment, you will be able to still maintain relatively normal serum K. That means a normal K, the punchline is the normal kidney can excrete a huge amount of K. 400 millimoles per day should be something that you can adapt to, not instantaneously. If I assault you with 400 millimoles of K, you're going to get hyperkalemic. Okay, but if I do that for sustained periods of time, you will maintain relatively normal serum K. That means that a normal kidney should be able to mount a measly 100 millimoles per day if you have a normal kidney, allowing for a little bit of aging, a little bit of mild renal impairment. I've just sort of arbitrarily plucked this number out of the air. This is not based in any particular science or published data. This is just based on intuition. All right, so take that as a grain of salt as you're using this to parse the clinical landscape. Okay, the other way, that's with a 24-hour urine K. The other tools that you have are TTKG. The quick aside is that the original espousers of TTKG, one of which is Orson Moe's, mentor back in the day, Mitch Halperin, who's now retired. But he wrote the original paper on TTKG, and then he wrote a follow-up paper and says, that wasn't such a great tool after all. It's still out there as a clinical tool, so I mention it. But essentially what he says is urine K to creatinine ratio is probably just as good, if not better, than a TTKG. So I think that's where most of us are using as a shorthand method of assessing urinary K excretion rates. Remember, you have to do some dimensional analysis to make that make sense. I've said this before, I'll make it quick. What you're trying to do when you do a K to creatinine ratio or even a urine protein to creatinine ratio is you're trying to express this in some milligrams or millimoles, some milligrams or millimoles in your numerator per 1 gram of creatinine. Okay, that's what you're trying to do. If you assume that most of us excrete about 1 gram of creatinine per day, then this number should approximate a 24-hour urine. That's the principle underlying the use of ratios to assess urinary handling of protein, phosphorus, if you express it in milligrams per gram, and you can do the same with K. K is different because the numerator is expressed in millimoles per liter. The denominator is expressed in milligrams per deciliter. So you have to do a little bit of work. You have to change the denominator into grams per liter. Okay, if you do that, then you'll get an ultimate, the liters cancel out, you'll get a final ratio that is in millimoles of K per gram of creatinine. Okay, and again, if we excrete 1 gram of creatinine, then this should approximate a 24-hour urine. Okay, that's what you'll do. Urine K to creatinine expressed that way will give you a rough estimate of a 24-hour urine, and I've still used 150 as a threshold value. Okay, so if you have that kind of, let's call it vigorous K excretion, it means that this hyperkalemia is not because the kidney is responsible. It's just you're just taking in so much K. Okay. Now I've again lowered it to 150. I'll give you some insights. All of us as we age, you guys are all young, you can excrete 400 millimoles of K. Maybe I can as well still, but all of us start to get a bit hypoaldo as we get older. Okay, our adrenal glands capacity to respond to K starts to go down with age. That's why I said, okay, you're managing a lot of older patients. Let's use 150. Okay. All right. So where am I? So let's go back to the text. Hyperkalemia due to tubular resistance of aldosterone. So I have to go where we're at. We're going down this part of the algorithm. Does the patient have these various causes of impaired K excretion, one of which is tubular resistance to aldosterone? Okay, that's where we're at. We're right here. Tubular resistance to aldosterone, or is there just plain old hypoaldosteronism? Okay. So we don't have to go over aldosterone physiology because you guys own that now. We've gone through that ad nauseum. So I can just move quickly through this. So the classic example of cause of resistance to aldosterone would be an example of a hyperkalemic distal RTA. Okay. So in this situation, we'll talk more about the RTAs when we talk about metabolic acidosis. There's a variety of causes. Here are some classic ones. I would say one of the most common ones are renal transplant and sickle cell disease. Okay, sickle cell has a number of effects on kidney for the nephrologists. One of them is hyperkalemic RTA. Another one is FSGS from hyperfiltration. There are effects on phosphate homeostasis. You get actually hyperphosphatemia. You can have hypouricosuriia or hypouricemia. There's a variety of effects of sickle cell. So one of which is a hyperkalemic RTA. Now, in this scenario, I have basically an impairment in the reclamation of sodium. Here we are in the collecting duct, right? I have impaired reclamation of sodium via ENaC, okay? And if I have impaired reclamation of sodium via ENaC, the lumen is less negative, right? We think of sodium reclamation, a cation, creating a negative luminal potential difference, which favors urinary excretion of potassium through these apical transport proteins you're all familiar with, ROMK and big K. Big K is flow stimulated. You're more familiar with ROMK, okay? So let me jump to another point. Any cause of low distal sodium delivery would impair caluresis. Okay, so anytime I have less generation of lumen negative potential difference through reabsorption of sodium via ENaC, that can cause impaired potassium excretion. So a cirrhotic who presents with hyperkalemia may present with hyperkalemia because of mineralocorticoid antagonists, right? I'm inhibiting the mineralocorticoid or I'm blocking the mineralocorticoid receptor. But some who are not even on spironolactone, just by virtue of very low effective circulating volume, can have impaired caluresis as well. Okay, so any cause, and sometimes your management says, let's give the patient salt water. Okay, that's how I'm going to manage hyperkalemia in this volume depleted patient. Just give them salt water. Okay. And so I can return to this part of our algorithm that handles this, right? How do I recognize this form of hyperkalemia from simply low effective circulating volume? I just look at my urine sodium. If that's low, that gives me the clue that one of the main mechanisms of impaired caluresis is low distal sodium delivery. Okay. All right. So that's why I guess I will also sort of highlight that sometimes you'll be sort of tempted to sort of say they're hyperkalemic, crank up on their furosemide. Well, if you cause them to get so volume contracted by doing that, that they're ultimately the net distal sodium delivery drops, then you'll actually impair caluresis in that patient. So furosemide does not always result in improved hyperkalemia. If you volume deplete someone enough that their net natriuresis down the road is diminished, their caluresis is diminished as well. Okay, so here again, now we can parse the rest of the conversation. Low aldo activity. All right, so patients with these with this branch of the hyperkalemic tree will have elevated aldosterone, right? You know this now. Stimulus of aldosterone release is angiotensin 2 and hyperkalemia, right? So if you have aldo resistance or ENaC blockade, then they're hyperkalemic. They're going to tend to have high aldo levels, okay? Now that's in contrast to the classic type 4 RTA, which is low renin, low aldo. We'll get to that in a different branch of the tree, but we can make that statement now and reinforce it later, okay? So in patients with hyperkalemic distal RTA, these patients may have impaired urine acidification, as the name implies as well. There's a couple of mechanisms of that, which we'll elucidate further in our discussion of metabolic acidosis. I'll just lob them at you now, okay? Hyperkalemia itself impairs ammoniogenesis, okay? And then impaired generation of lumen negative charge, right? Also impairs the extrusion of protons, right? You'll recall the alpha intercalated cells rely on that same negative potential difference to dump protons into the lumen as well, right? So again, hyperkalemic distal RTA will have typically defects in urinary acidification. Now, patients can have variable urine pH. I'll make that point that sort of softens this statement of what pH you're going to find in hyperkalemic distal RTAs, okay, when we get to metabolic acidosis. Let's move on to drugs. Classic drugs that will tend towards hyperkalemia that fit within this tubular resistance to aldosterone branch of the tree would be ENaC blockade, right? So amiloride and tramtarine will be classic ENaC blockade, ENaC blockers. But don't forget about these less classic ENaC blockers. We don't use much IV pentamidine anymore, but that actually does block ENaC. Trimethoprim in high-dose Bactrim can block ENaC as well, and essentially function similar to amiloride and triamterene. Spironolactone obviously cause a form of aldosterone resistance that we don't need to belabor. I will, however, say that this will have a true two-pronged effect on potassium excretion. Remember that aldosterone binding the mineralocorticoid receptor enhances sodium reclamation via ENaC, creating that lumen negative potential difference. Don't forget, however, that aldosterone also stimulates K-conductance. So the hyperkalemia from an aldosterone antagonist is going to be twofold, right, in mechanism, not just generating the lumen negative potential difference, but also reducing apical membrane conductivity for potassium through ROMK especially. Okay. All right. So we will move on to calcineurin inhibitors. I'll make the point, as I have in the past, that one of the sort of mechanisms that calcineurin cause, or the mechanisms whereby calcineurin cause hypertension, hyperkalemia, and metabolic acidosis is a mechanism akin to pseudo hypoaldosteronism type 2. So you can see that that discussion lies ahead. So we can reinforce it with kind of two different clinical scenarios. Okay. Calcineurin inhibitors approximate the biology of Gordon syndrome, pseudo hypoaldosteronism type 2. All right. So the hyperkalemia is a little dirtier though. People have shown effects on renin release, okay, through calcineurin inhibition. You would therefore anticipate that with cyclosporin, you will see hyporeninemic hypoaldosteronism. That is inconsistent. Some literature shows that, others do not, okay? So that's an inconsistent finding, but it's based on a biology that is understood in which cyclosporin affects renin release through effects on prostaglandins, okay? Prostaglandins have a multitude of complicated effects on kidney biology. Prostaglandins cause natriuresis, antinatriuresis, vasoconstriction, vasodilation. Remember, prostaglandins come in all kinds of flavors. Prostaglandin E, thromboxane is derived from cyclooxygenase biology. So again, it's perhaps fair for me to do a little hand waving here and say COX-2 inhibition can be leveraged to explain some of the effects on renin release. Okay, but here's that Gordon syndrome physiology. It essentially upregulates, especially DCT transporters. Remember, NCC is sodium chloride cotransport. Here we are in the distal convoluted tubule, right? So NCC is this sodium chloride cotransporter. We'll get to Gordon syndrome, which is a defect in these regulators, WINKs, as well as Cullen-3 and Kelch-like family protein 3 that regulates NCC as well. These are underpinning Gordon syndrome. You can see that calcineurin interacts with these regulators of NCC. You can see that also the WINKs interact with potassium channels in the collecting duct. Okay, so Gordon syndrome and calcineurin inhibitors cause hypertension by upregulating NCC activity. Even though it's not as well spelt out in the thick ascending limb, there is WINK activity in the thick ascending limb as well. It's not as well delineated as DCT physiology, but presumably NCC transport is upregulated through WINK regulation as well. Okay, so again, calcineurin inhibitors cause sodium retention. Now, if I'm reabsorbing salt in the DCT, that means downstream delivery of salt goes down. That means I have less sodium to reabsorb. That means I cannot create that lumen negative potential difference as effectively. So that's one mechanism whereby calcineurin inhibitors and Gordon syndromes cause hyperkalemia. Reduced distal sodium delivery. We've gone over that, all right, okay? But you can see that there's also an effect of WINKs on apical membrane channel conductance of K. You essentially get through certain WINK mutations. It's very complicated. There's all this, there's WINK1, WINK4, there's different splice variants. It's hard, and there's sort of double negatives in the regulatory pathways and inhibition of an inhibitor. The sum total, I would say, is that certain WINK mutations can downregulate ROM-K channel conductance, okay, and big K channel conductance as well. And if that's the case, K secretion is diminished, okay? All right. The metabolic acidosis is also from impaired generation of lumen negative potential difference. inhibiting alpha intercalated cell secretion of protons, right? Okay. I know we're moving fast for our fellowship candidates. That's because our fellows have seen this so many times. And I'm not seeing too many wrinkled brows. I can see that there's processing keeping up. Okay. So I can keep moving. All right. That's why we have to make it to in person as much as possible, so I can see those brows and pace accordingly. All right, so let's then move to a different type of hypoaldosteronism, which is relatively quick because it makes sense. It's basically a loss of function mutation in the mineralocorticoid receptor. So one can anticipate what you're going to see. It's basically like I'm treating a patient with spironolactone, right, or eplerenone. I'm going to get salt wasting and hyperkalemia, right? There is also a pulmonary phenotype similar to, remember, you recall from cystic fibrosis, you handle mucus in the lung by regulating chloride transport in that case. There is a sodium transporter as well that is also in part regulated by aldosterone. Again, highlighting the repurposing of nature of transporters across different tissues. You have an aldosterone receptor in your gut. And so it stands to reason that you might have a pulmonary manifestation as well, where you have impaired mucus clearance in certain cases of pseudohypoaldosteronism type 1. Okay. There's autosomal dominant and recessive forms, one of which is an ENaC channel defect. The other is a mineralocorticoid defect. And you can see that the pulmonary phenotype is more common with the ENaC defect. Okay. Aldo will be predictably high. You'll treat these patients with lots of salt. Okay. And that's because I'll just use that to highlight. Remember, one way to increase K loss is flooding the zone with salt and water. When you increase tubular flow rate, you stimulate big K, okay? The other thing that you do by giving sodium chloride to a hyperkalemic patient is you reduce the K concentration of the lumen, right? Because if K is leaving the cell into the lumen, further K egress is impaired by rising luminal K concentration. If you can keep luminal K concentration low by enhancing tubular flow rates, then that will also enhance K excretion. Okay, so tubular flow rate is an important way you overcome hyperkalemia. That's why, you might use saline plus loop diuretics to enhance caluresis, right? Because big K is stimulated by tubular flow rates, and tubular flow rates keep luminal K concentration low. See nods, I can keep moving. All right, so pseudohypoaldosteronism type 2, I think we've talked about, so I think, move reasonably quickly. This is a genetic disease, presents with essentially the phenotype of a calcineurin inhibitor exposure, hyperkalemia, metabolic acidosis. Renin is typically suppressed. Why? Because their volume expanded, remember? And so we talked about renin release being determined in part by beta receptors as well as vascular wall stretch. So in this case, ECF, or effective circulating volume, is increased. Increased stretch actually decreases renin release. Okay. And so these patients will be typically hyporeninemic. Aldosterone levels are going to be variable. Why? Well, low renin leads to low angiotensin 2, which leads to low aldosterone. But hyperkalemia, we know, is a direct stimulus of aldosterone release. And so hyperkalemia can moderate that aldo suppression, right? These patients also seem to have some tendency towards hypercalciuria and nephrolithiasis. Exactly how that manifests is multifactorial. Some of that could be from the chronic metabolic acidosis. We'll talk about this in our stone block or stone escolita. That would cause hypocitraturia. Metabolic acidosis itself causes a tendency to bone demineralization and hypercalciuria as well. There's a direct effect of metabolic acidosis on TRPV5 activity. Okay. TRPV5 mediates apical membrane transport in the DCT of calcium. That's in part influenced by metabolic acidosis. We'll talk about all of those things again in our nephrolithiasis conversation down the road. Okay. But those make sense is what I'm trying to say. Hopefully it's not rote memorization. You can, weave all of this stuff together by me repeatedly emphasizing these concepts. Okay. Here I get to hand wave. I prepared you for the fact that, gosh, there's a lot of complexity to Wnt biology, okay? Wnt kinases refer to with no lysine. K is the abbreviation for lysine, if you remember your biochemistry. So these are phosphorylating enzymes, hence kinase, Wnt kinases. Cullen-3, Kelch-like, human protein 3 are other regulators that interact to ultimately regulate NCC, NKCC2, which is your thick ascending limb, loops, diuretic sensitive transporter, ROMK, some big K regulation as well. Okay. So these are generally autosomal dominant, though there is some variable patterns of inheritance for the Kelch-like protein mutation. I've talked about the NCC effects. I've talked about the reduced sodium delivery to the distal nephron, right? I've talked about hyperkalemia being an effect of that distal sodium delivery as well as direct effects on K channels. Metabolic acidosis, I've said, is two-pronged. We'll talk about this more. Ammoniogenesis is downregulated in any cause of hyperkalemia. We'll talk about that as we talk about metabolic acidosis in that later conversation. The reduced lumen negative charge would cause a tendency to metabolic acidosis. And then the hypercalciuria may involve some regulated TRPV5 activity. Treatment is often sort of grounded on thiazide diuretic therapy, right? If much of this is because of upregulation of NCC, well, let's block NCC. And the hypertension should get better, the hyperkalemia should get better, and some of that metabolic acidosis should get better. This is actually well described in animal models of pseudohyperaldosteronism. Thiazide diuretics essentially rescues the phenotype. But you can use this at the bedside as well in transplant clinic. If you have a hyperkalemic, hypertensive patient on calcineurin inhibitors, often we try to sort of limit our use of diuretics because the creatinine bumps a little bit sometimes. But on the flip side, you should look to these as a reliable partner for targeting the biology of their clinical problems, right?